attendance from our end. But I am very appreciative, Doctor, of you being here to do your presentation, and you can start at any time.
There. Can you guys see my slides?
Yes, ma'am.
Oh, good. My little bar with the mute unmute disappeared as well, and I couldn't find it. So I was talking to myself. Well, I just wanted to talk a little bit about maternal morbidity and give an update of what we've been doing in our affinity group for the last couple of months. I gave a similar talk to the MAC a couple of months back. And so this has just been updated from that. Let's see. I cannot go forward. Let's see here.
I'm hitting your enter button, Dr. Terrio.
Aha, okay. There it is. First of all, a maternal death is defined as being pregnant within 1 year prior to death or pregnant at the time of death, and that's from any cause. And so it's basically when you're pregnant and up to a year after you're pregnant with that baby. And in Kentucky in 2018, we had 76 maternal deaths. And just to give an idea, usually we're right around 700, maybe a little bit more than 700 maternal deaths in the United States every year. So Kentucky having 76 of them is a big number. And you can look at the trends. This came from the CDC. The trends in pregnancy-related mortality has really gone up steadily over the last couple of decades. And we're right now at about 17 per 100,000 live births for the United States. When we break it down by race and ethnicity, you can see that Black Americans or American women have a much higher chance of having a pregnancy-related death than any other race in the United States. And also interestingly, American Indian and Alaskan Native used to be really high, and that has gone down over the last several years. But for African Americans, that number has stayed pretty high. And it's just disproportionate to what the other groups are. So we have a maternal mortality annual report that the Department for Public Health, Maternal and Child Health Division has to put out every year. And our last one came out in November, and it's available on the cabinet website, came out in November of 2020. And how that report has come about is we have a maternal mortality review committee, and that committee has a bunch of people on it from public health, Medicaid, DCBS, behavioral health. We also have law enforcement on there, domestic violence. We have the coroner and the medical examiner. We have providers from anesthesia and women's health. We have people from all of the different birthing hospitals on that committee. And the committee comes together. It's actually a horrible, depressing day, and reviews the cases of all of these deaths. Actually, we meet several times a year, but we go over it with a fine-tooth comb. We get everything that we can, every record we can. If the mom had anything to do with law enforcement, we can get those records. If they had any issues with behavioral health or Department for Community-Based Services and foster care, we get that information. We look up CASPER reports, and CASPER is the log of controlled substances for each patient. So we can get the CASPER reports. And then we try and answer some questions with all of this information. We try and answer, was this death preventable? What contributed to the death? and things like that, and put all of that together and come out with the report. So you can imagine this takes a while to do. And so the report that came out in November of 2020 actually, I think, stops at data from 2018. So it's about 2 years behind because it takes a while to go through all of the information. And so the next couple of slides are going to be graphs and things from that November 2020 report. And so this is Kentucky deaths, and you can see it's just from 2013 to 2018. And again, it's steadily going up, and with the 76 deaths in 2018. And again, this is a maternal death that happened when the mom was pregnant or within 1 year of after that pregnancy. And then in Kentucky, we also have a racial disparity because our rate for maternal deaths for white women is right at 17, which is a little bit higher than the national rate. And our rate for Black women is 42. So it's so much higher than our rate for white women. And that is, that's kind of what we see nationwide, that you just have a much higher death rate if you're Black. You have a much higher chance of dying while you're pregnant or within a year after you're pregnant. And so this is actually really concerning. And when we look more closely at that data, the deaths among the Black women were higher in Louisville and in Lexington. And that is, interestingly, where our providers are, where the birthing hospitals are, where the big referral centers are. So they have maternal transport and infant transport to these centers. So these are where the specialists are. And that doesn't make any sense to me, because when I think of Kentucky, I kind of think of a rural state, and I think, oh, well, if we have this issue, it's probably because we're rural. You know, people don't have access to care because they're out in the middle of nowhere, you know, in the state. And that's actually not true for our Black moms. So it's really important to look at the services and supports that are in our urban centers and to see what is going on there. You know, if these services exist, why is there a disconnect? Why can't the Black women get the same care as the white women in our cities? So, so that's, you know, a big problem. Now, we do have some things that have started, for example, the Healthy Start program, which is in Louisville, and that's really aimed at reducing infant mortality. And it's an in-home program targeted at certain zip codes within Louisville with the highest infant mortality rates. But the workers will go into the homes and they provide screening services. They provide developmental information, parenting classes, things like that, encourage self-care for the mom and pediatric care for the baby. So it's more of an educational program. And so this is something we have to follow it a little bit longer to see how it's doing, but this is something aimed at reducing infant mortality, which of course is also linked to maternal mortality. Getting back to our November 2020 report, one of the things that the committee does is specify whether a death is natural or an accident or a homicide or a suicide. And natural doesn't mean it was okay. It could have been an asthma attack, you know, an asthma attack and you died. So that would be a classified as a natural death, although we can all say in this day and age that shouldn't happen. So it doesn't mean it was okay. It just means that it wasn't an accident and it wasn't one of these other categories. So we also look at, was the death preventable? So for example, the asthma attack, yes, that is preventable. That should not have happened with appropriate care. And it certainly shouldn't have happened, you know, in the United States with all of the healthcare that we have in this country. So was the death preventable? When we looked at our numbers, the committee came up with 79% of the time they said the death was preventable. It could have been that asthma attack. It could have been a postpartum hemorrhage, something like that. Death was preventable. Other times, about 16%, the death was not preventable. Well, what could that have been? That could have been, I don't know, a cancer death, something like that. And then 5% of the time, the death, it was unknown whether it was preventable or not. But just look at that. I mean, 80% of the time it was preventable. So that means we can control this. We can, target interventions, and we can actually do something to decrease these deaths. The other thing we looked at was substance use as a contributing factor to the deaths. And about half of the time, we came up with that substance use was a contributing factor, and it was preventable. And so you can see that just targeting things for substance use will really help decrease the deaths that we see in Kentucky. A key challenge thinking about our systems in Kentucky for pregnancy care and post-pregnancy care is trying to improve or increase postpartum care. We looked at our numbers, and a lot of our moms don't go for that all-important postpartum care visit. You guys know how important that is. And now, I mean, when I had my babies, the youngest one is almost 22 now. They only had one postpartum care visit. Now the ACOG says you have to have 2 visits, one at 2 weeks, one at 6 weeks. And so I think slowly people are starting to do that, but it's still, it's not every provider sees 2 visits as important, and not every mom attends 2 visits. And a lot of things happen at those visits. You have screenings for postpartum depression, you have screenings for substance use. You talk about spreading out your births, more of a family planning. Do you want to have another baby right away? If not, what do you want to do about it? Different things like that. And just good, good healthy spacing of pregnancies will make moms healthier and babies healthier. So lots of things are supposed to be going on at these postpartum care visits. And I put quality in there because I think we really need to specify what happens. Like, we say it's important, we say it's it has screenings and things, but it might be time to actually list what is a good postpartum visit. What is a high quality postpartum visit? What do we want our moms to get out of these visits when they go? Because it has to be important enough to them. They have to get something out of it. So that's something that we really need to look at in our system of care. Our MCO partners, and some of you guys are on this call, know all of these things. They provide care management services for women with high-risk pregnancies. All of them do. All of them have some sort of incentive programs for moms attending the prenatal visits as well as postpartum visits. Many have apps that the moms can use that help not only remind them about visits and whatnot, but kind of teach them along the way what to expect while you're pregnant, and help them prepare for the baby. So these are great incentives that our MCO partners have for our moms now in Kentucky. Well, Kentucky was chosen as one of 9 states to participate in a postpartum care affinity group. And the goals really were to develop quality indicators to improve postpartum care quantity and quality, as well as increase postpartum care follow-up rates at the 2-week visit and at the 6-week visit. And then a third thing that we really want to work on, we haven't started yet, is increasing utilization of long-acting reversible contraceptives in our population. When we looked at our numbers, and we've toyed with the numbers and changed them around, and I think we finally got some accurate numbers now, that we've seen that overall 64% of our moms attend a postpartum care visit, at least one within 60 days postpartum. We would like to increase that amount to at least 75% by the summer of 2023. And we looked specifically at the moms with a SUD diagnosis and saw that 68% of those moms go to one of their postpartum care visits. So that was great, but we want to make that better. We want to improve that to at least 85% or more. Actually, it would be great for both of these if it was 100%. I don't know if we can do that because life kind of gets in the way sometimes, but it is an important thing to do. And we have to make it worth it for the moms. We have to develop and define the content of what we want to happen at those visits, and we have to make sure it happens so moms are getting good quality care. Other things that the Affinity group has come up with to try and get at some of these things is, for example, making the postpartum care visit appointment prior to discharge from the hospital. And that might be helpful. You know, you have a newborn baby, you go home and you're busy, you're tired, and you kind of forget. It's easier if that appointment is already on your books, for example. So that's one thing that we've thought of. We've also thought about asking the MCOs to report monthly about the beneficiaries that attend their postpartum care visits and really make a run chart to see, you know, who's going and who's not, and spread it out, looking at beneficiaries with SUD and not SUD to see if we can do any more targeting. One thing that we also realized is not all of the MCOs know when somebody's pregnant. So what is that, third bullet down, standardize an NOP form. That's a notification of pregnancy form. And so sometimes the MCOs don't really know unless they are coming in as a new patient and happen to be pregnant, and that's on their eligibility report, or the patient goes to an OBGYN and the OB sends in a claim that has a pregnancy diagnosis on the claim, but nothing is really organized to tell us what is happening. And so we thought that if we would do a notification of pregnancy form that all of the MCOs used, and on that form, not only have if mom is pregnant or not, but list, you know, some high-risk indicators, then the mom can be referred directly to some care management program and help, you know, link her into services that she may need for the pregnancy. So, so we've thought about doing that. We've, of course, explored options about how to encourage the providers and the moms to attend more than one prenatal care visit, that 2-week visit and the 6-week visit. And we wanted to, currently, mom loses her Medicaid unless she has another reason to be on Medicaid at 6 weeks. And so we were thinking of providing the postpartum care through 1 year postpartum. That is going to happen. It's been, it's a SPA that needs to be done. And so that will be done next year, which is the earliest we can get that done, but we are moving in the right direction for that one. And then there already have patient incentives, but it might be important to have additional incentives for providers to conduct those postpartum care visits if we want to get everybody seen. The last thing that the Affinity group is doing right now is conducting stakeholder meetings to learn more about other programs in Kentucky and how we can learn from each other and work together to address improving postpartum care in Kentucky. And that's all I have. Do you guys have any questions?
Hi, this is Shannon from WellCare. I loved that presentation. Thank you so much. Is that something that you will send out to those of us on the call?
Oh, sure. We can send that out. I can send it to you, Charlie.
It'll be posted on this TAC's website, on the Nursing Services website. It's for everybody to have access to it.
Wonderful. Thank you so much.
Any other questions? Well, thank you, everybody.
Thank
Thanks,
you
Mr.
very,
Chair.
very much. That was wonderful
Oh,
and
you're
very
welcome.
informative.
So Lisa, we never had anybody else come in, so you don't have a quorum, so, I mean, if you have anything else you want to discuss, or you can adjourn or whatever.
No, ma'am, I guess we'll just adjourn and I'll try to get together with our missing members and see work on our next agenda for sure.
Okay.
So, but I will be reaching out to our chair.
Okay, that'd be great.
Okay.
Your next meeting is actually next month. Let me look just to be sure, because this was a makeup.
Right, yeah, this was a makeup.
I think, let's see, is October the 7th at 3:30. So, wait a minute, at 3:30?
Must be 3 o'clock, right?
Yeah, 3 o'clock. So it's be October the 7th at 3 o'clock.
Okay. All right, thank you very much. Thank you, everyone.
Thanks, all.
Thank you.
Thank you.